Hello everyone and welcome to our event today, the Service Providers Network event entitled Psychedelics, Trauma and Addiction. So thank you all for being here today. Our Service Provider Network event has been jointly organised by the South Eastern Drug and Alcohol Connection Service and the Western Drug and Alcohol Connection Service. So both South Eastern and Western Connection Services are based in Assert and are funded by the Public Health Agency under Northern Ireland's Alcohol and Drug Strategy. So you will find a Drug and Alcohol Connections team in each of the 5 trust areas within Northern Ireland, and we work towards addressing issues around drug and alcohol use through delivering awareness raising sessions, signposting to services, responding to drug and alcohol related incidents, providing early warnings around current drug and alcohol trends, and developing and promoting campaigns. So part of our work involves working closely with our local drug and alcohol coordination team, which we call the DACT. So the DACT brings together a range of statutory and voluntary organisations to promote a coordinated local approach to addressing alcohol and other drug issues. So through our DACT, we organise approximately 2 service provider networking events each year, of which many of you have attended in the past. So we normally provide you with a lovely breakfast and give you plenty of opportunity to meet and network with your colleagues. So apologies, we're online today on Zoom and you've had to make your own breakfast this morning. So this year, given the current climate, we decided to do things a little differently and decided to try holding one of these events online. So a little bit about the background to this event. I've worked for Assert for about 6 years now, and over the last number of years there has been a lot of interesting research coming out about the potential of psychedelics to treat a range of mental health, addictions and chronic health conditions. I have been following this closely over the last 5 or so years. Also, there's been a lot of talk about adverse childhood experiences and the impact of childhood trauma on mental and physical health. Then last year, Michael Pollan's book, How to Change Your Mind, which looks in depth at the healing potential of psychedelics, became a New York Times bestseller. So I know from conversations I've had with many of you that there has been a lot of interest locally in this topic. So we thought it might be an interesting one to look at in our event. So it was actually about 2 years ago that I had the opportunity to attend a 2-day workshop in Cork led by Dr. Gabor Mate. Many of you may know him, have heard of him. He is a Canadian medical doctor and one of the world's leading experts on trauma and addiction. He worked for many years on the Lower East Side of Vancouver with people who inject drugs. So when I heard he was speaking in Cork at a workshop, I got in touch with my sister Ashley, and I phoned her up and said that we had to go, we had to be there. So she is a medical doctor and also works with people with addiction problems and injection heroin users in Edinburgh. So off we went to Cork, and Ashley got talking to Dr. Mate during one of the breaks. And she spoke to him about the challenges she faced working with this group of clients and the severe trauma they had. So he actually invited her to go on a retreat with him to the traditional Shipibo healers in the Peruvian Amazon. And I will let her tell the rest of the story. But since then, she's now involved along with James and others in setting up the Psychedelics Health Professionals Network. And we have the privilege of herself and Dr. James Hawkins being here to talk with us today. So let me introduce our first speaker, who is Dr. James Hawkins. He is a medical doctor and psychotherapist based in Edinburgh. In the last number of years, he has had a growing interest in the field of psychedelics to treat problems related to trauma and addiction. He has been instrumental in setting up the Psychedelic Health Professionals Network, of which he will tell you more in his talk. So he is going to give us an overview of the latest research and developments in the field of psychedelics, trauma and addiction.
Good morning. Thank you for inviting me to give this talk on psychedelics, trauma and addiction. We have relatively limited time, so this is the key aim, to give you some idea of the current state of the research and particularly to focus in on trauma and substance use problems. And you can see from the 2 quotations on this page It's something about not necessarily accepting the conventional views about this, but to see what the data suggest are increasingly supported applications of psychedelics therapeutically, but also, bottom right, that quotation, important to keep an open mind, but not so open that our brains fall out. And I'd like, fairly briefly, to move across these 5 questions. What are psychedelics? How do they work? The risks involved, potentially, their effectiveness, and what next steps might be in this area. I'm going to be moving quite fast, so it's to give you an idea of the territory. Please, if you're interested, come on back to the slides after the talk. There's plenty of research references and other links you can follow up to dig down into the material in more detail. So, first of these questions, what are psychedelics? The term itself, introduced in the 1950s by Humphrey Osmond, meaning mind revealing. You can see it's rather an interesting kind of fruit salad of different substances. Classic psychedelics, which we hear a lot about, very interesting indeed. We've got the entactogens, empathogens, with MDMA galloping in really as probably the next of these substances that will be licensed. The dissociative anesthetics, I highlight them particularly because ketamine is already being used in the health service, and this will continue and will evolve. There's THC, the cannabis derivative, ibogaine, salvia, so you can see quite a mixed bag here. And why are these chemically different substances all being grouped together? Well, as you can see this from this quote by Grinspoon and Bacala, there is something about the overlap in their effects on consciousness that seems particularly interesting, and it teaches us a lot about consciousness, I think, but also it has real therapeutic potential. And it is worth pointing out, as you can see from the comments at the bottom of the page, that there was a lot of research around in the 50s and 60s, more than 1,000 clinical papers, 6 international conferences. And this was interrupted not for scientific reasons, it was interrupted for political reasons. And that was a travesty, actually. There are many, many people who've suffered unnecessarily because the research on these drugs was interrupted in the way that it was. Luckily, happily, we are beginning to pick up those trains of information to follow them up, to actually be able to find how these drugs can be useful for many forms of suffering that are currently very hard to treat. I'm going to start talking a bit more about the dissociative anesthetics, just briefly, but these are the ones that are currently available. And then I'd like to say a little about classic psychedelics, a little about the entactogen, empathogen MDMA. Okay. So the dissociative anesthetic that's been used particularly is the NMDA antagonist ketamine, with, as you can see, a whole series of actions in the body. And here are 3 major reviews, all recent, indicating non-anesthetic uses of ketamine. And these would be worth pursuing, particularly if one was wanting to set up a clinic, as for example Ben Sesser is in Bristol, this year, next year, before MDMA becomes licensed. One can start with ketamine-assisted psychotherapy. And here are a number of links one could pursue if one was wanting to look at this in more detail, learn more about it. There are large amounts of information, there are training courses, and so on that can be pursued. And then moving on quite quickly here to the classic psychedelics, which are serotonin 2A receptor agonists. So LSD, derivative of ergot, psilocybin from mushrooms, of course, DMT, one sees it in ayahuasca and toad venom, mescaline from cactus. So kind of plant-associated materials. And these classic psychedelics all share this 5-HT2A receptor agonism. So they actually act on the 5-HT2A receptor. And in doing so, they produce a variety of effects we'll talk about. But kind of galloping in rather faster now are the entactogens, particularly MDMA, which is likely to be licensed probably within the next 18 months to 2 years. So that's almost certainly going to be the next substance that we can use therapeutically and legally. And MDMA has moved forward so very well largely because of MAPS, the Multidisciplinary Association, who've raised the money to produce a whole series of really impressive research studies. There's a nice Tim Ferriss show interview with Rick Doblin from earlier this month. Rick is the founder of MAPS, and it really gives you great background on what's been happening with MDMA and PTSD. And just at the bottom there, The Trip of Compassion is a great 84-minute film that you can download. It costs you £3 or so to hire it, but it shows MDMA-assisted psychotherapy for PTSD very engagingly. So that's a little bit about what the psychedelics are. How do they work? Well, there are lots of different ways of seeing this. One way would be highly biological, and there's no doubt that these do act biologically, both through the 5-HT2A receptor, through disrupting the default mode network, through increasing neuroplasticity, and so on. There's also major function on memory access, deep psychological effects around trauma processing and insight. There's fascinating effects on well-being. If you do general public surveys and you follow people up for maybe a year or more after they've taken a psychedelic trip, they will pretty routinely describe improvements in well-being, pro-social gratitude, social relationships, and so on. And then the transpersonal at the Johns Hopkins Research Center, which is the main research center really in the world, actually. They're doing a study with religious leaders, getting them to come in and take psilocybin and then report what sense they make of it, because it's absolutely mind-shifting. So the classic psychedelics are working, if you block the 5-HT2A receptor, they simply don't work. So it's very clear that they initiate activity there. It produces this disintegration or this real disruption of the resting default network, which to an extent we can think of as ego functions. It opens this window of neuroplasticity, which allows major changes. And one nice way of seeing it is the idea that it's a little bit like our brain is a mountain, a snow-covered mountain, with these deep ski tracks or toboggan tracks of habitual ways of seeing and acting. And that the psychedelic trip is like a heavy fall of snow. And then you can, particularly if you work within that neuroplastic kind of window, you can start to develop new habit patterns and new ways of seeing things that can be immensely helpful. I helped somebody recently who was a lifelong smoker who had tried many times to try and stop smoking. He has macular degeneration, so he was told that he would go blind and that stopping smoking was the single most powerful thing he could do. And it was fascinating because after the 2 trips he took in Holland, he went, I actually don't want, I'm just really not interested in smoking. Which was, I mean, it's not necessarily that you get such simple, wonderful kind of responses, but they do occur like that. Now, the entactogens, the MDMA, is more complex in some ways. So you do get the 5-HT2A action, as well as other serotonin effects, but you also get these other effects, including things like release of oxytocin. The aim being, at least in the work on PTSD, that you're wanting to open up this window of tolerance where people won't be overwhelmed by memories and trauma-associated experience, but they are actually able to move out of the kind of numbing and the denial. So you open up a window for doing therapeutic work. On many of these slides, you'll see links to the literature where the ideas come from. So if you want to go digging after this talk, there's many hours of exploration that you can put in. So that's a little bit about the fairly disparate but fascinating ragbag of substances that within this psychedelic field. There's clearly a whole series of ways that they work biochemically, but they do produce very similar overlapping effects. What are the risks? Well, less than one would think. So David Nutt produced this fairly dramatic paper 10 years ago in The Lancet, where they really tried to look logically at how much damage were produced by different drugs. That procedure was repeated 5 years later with European drug experts, and then again last year in Australia. And they've all come up with very similar conclusions. So you'll probably all be aware of this at the time, in 2010, rather shocking finding that harm to the users are in blue, harm to others in red. And you can see alcohol far and away the most damaging. And encouragingly, down at the bottom there, we've got psilocybin mushrooms at the far right. LSD and MDMA also far right. Even ketamine is only halfway down. And then, in a sense, you know, poking the lion, Carbonaro and others from John Hopkins put out an internet survey where they asked people who were prepared to talk to them about their worst psychedelic experience. And they got nearly 2,000 responses. And what they found was that these were specifically with psilocybin. Now remember, this is not the chances of any old person taking psilocybin and having this kind of experience. This is experienced users describing their worst ever trip. And not all experienced users, the ones who wanted to come in and talk about their worst trip. So it's a very kind of selected group. Nearly 40% said it was amongst the top 5 most challenging experiences of their life. 11% put self or others at risk of harm. Dose, duration, difficulty of the experience, absence of physical comfort and social support were all risk factors. Now, this is, I think, the thing that absolutely fascinates me, that here with this group who had had this particularly difficult experience, 84% said they'd benefited. 84% said they benefited, and nearly half said they actually would like to go back and repeat the whole thing because it had been so helpful. I think that's fairly mind-blowing. You can see the original paper on the left there, and one of Carbonaro's colleagues in the bottom left giving a lecture about these findings. And this is actually from my own website. This is just me pointing out that there are exclusion criteria. Things like family histories of psychotic disorder and so on. You do need to be careful what other drugs are being taken. What's particularly tricky in some ways with something like psilocybin or LSD is that you're not wanting to have people taking SSRIs, which means you need to withdraw them before you give them that particular psychedelic. Set and setting, of course, crucially important. The overall message is go into this stuff carefully and thoughtfully. Otherwise, you're likely to get your fingers burned. But these are surprisingly safe substances when used responsibly. How effective are they? Well, this is a paper from last month, actually, in the American Journal of Psychiatry, reviewing all the recent research up to the middle of last year. And you can see that basically the FDA have given MDMA for PTSD and psilocybin for treatment-resistant depression breakthrough therapy status. Psilocybin also clearly supported for end-of-life related anxiety. Lots of other emerging research too, including a good deal since the middle of last year. This is a year ago that this paper was looking. And if you go into clinicaltrials.gov, which is an American website listing the vast majority of current Western clinical trials, we're looking at 49 studies on psilocybin, 86 on MDMA, many more on ketamine, though not many on ketamine-enhanced psychotherapy, many more on cannabis. Again, not so many, nothing like as many on psychotherapy-related studies. And you can see with the psilocybin, for example, depression, substance use, healthy subjects, adaptation to challenging circumstance, meditative studies. They're using psilocybin during meditation retreats, for example. Very, very interesting work. And worthwhile noting that most of these studies are at best phase 2, but we do have phase 3. And so there's a recent phase 3 from Imperial College down in London. And then a whole bunch of others galloping up the straight. So Compass Pathways has this big 216 participant study on treatment-resistant depression. USONA Institute in the States has another biggish study. There's an absolutely fascinating one down under substance use. We've got New York University with this 180, 90 in the placebo arm and 90 in the psilocybin arm for alcohol use disorder. And that's due to complete at the end of this year. And there's a nice article actually by Robin Carhart-Harris from Imperial on their study, which still hasn't, it's due to come out in a research paper later this year, but he was reporting unofficially on the findings and saying the preliminary analysis of psilocybin versus an antidepressant, an SSRI, I think they were using citalopram, showing what he called game-changing results. And, not only game-changing results, but, good tolerability, not the side effects one would see with SSRIs, improved well-being. And he pointed out that it was very likely that psilocybin is going to be licensed within 5 years, but also pointing out that, for example, in Oregon, it looks like they'll be using it within a year, using a particular initiative that allows regulated therapy. So this is quite possible that we have ketamine already, MDMA probably within 18 months to 2 years, psilocybin probably within 5, but possibly able to use it before that. And the MDMA, crashingly, it's about PTSD, though I will say a little bit about an interesting set of findings from Bristol and Ben Sessa with alcohol use disorder. But you can see these D numbers, effect size of 1.58 for the 6 phase 2 trials using MDMA and PTSD. That's an extraordinarily powerful effect with actually further improvement at 1 year follow-up. These are game-changing results. With this kind of pattern of intervention, with 3 preparatory sessions, an MDMA session, 3 integrative, another MDMA, 3 integrative, and then quite possibly a third. But you're looking at, these are people, I think in one of the classic studies, these were treatment-resistant PTSD sufferers, on average had had the disorder for 17 years, and 68% not meeting criteria for PTSD at 1 year follow-up. That's just fascinating. And this is another recent paper just looking at modes of action, but I just point out that probably for general public and diverse populations, actually mystical effects, at least for the classic psychedelics, peak experience effects, I can talk more about these, are probably the major factor in improving well-being. But for subjects who are struggling more, it may be that these insight effects, trauma processing effects, are actually more important. Very interesting to monitor the literature and see how that evolves. And we are talking, of course, about childhood adversity. intriguing, worrying, upsetting to see this. And this third paragraph, approximately 1/3 of all mental disorders worldwide can be attributed to exposure to childhood adversity. So you're looking at huge factors in childhood. You can always go back to these slides. And it's not just in childhood. So you've got these childhood experiences, but then you've got life events as adults. You've got triggering factors. So there's a whole ladder of effects. And what about substance use? Well, very encouraging findings. This is an early psilocybin case series by Bogenschultz, but this one here that I've marked, the clinical trials Gov one, that's the 180, 90 in each arm, which is a really interesting study coming down the straight. We've got some evidence for ayahuasca and ibogaine and ketamine, of course, and LSD, actually. In this systematic review, its use in alcohol use disorders was the main area that it has been supported. This is the little case series from Ben Sessa. I spoke to him a couple of weeks ago, actually, on the phone, and he gave me these results. They're not reported yet. Now, these are so in a small case series of people who were getting the best alcohol services intervention from Bristol at 9-month follow-up. They had 24% who, well, they basically had 76% who'd gone back to their previous level of drinking by 9 months follow-up, which is depressing. But actually, if you look at the field, as you guys will know better than me, that's actually not a bad outcome if you look across worldwide outcomes. This is the case series using MDMA, and it's just kind of extraordinary, actually, that at 9-month follow-up, we've got only 12% who've reverted to pre-drinking behavior at 9-month follow-up, to pre-therapy drinking behaviors. That's obviously needs to be replicated and so on, but it certainly suggests that it's not just classic psychedelics, but MDMA too has something to offer. Next steps. I hope you liked the cartoon. I thought it was rather fun. Well, I think you need a supported drug and alcohol service. You need an interested prescriber. You need good therapists. You need some training. And arguably, you need some personal experience. I'll just move quickly across those 5 areas. So yes, a supportive service. Yes, an interested psychiatrist. This is Ben Sessa again. And as you can see, he's aiming to start a clinic this year using ketamine-assisted psychotherapy with MDMA coming down the straight pretty fast and psilocybin following. You need good therapists. That may sound obvious. This may shock you. This is a pretty typical finding that if you actually rate therapists on their outcomes, about 1/6 are excellent, about 1/6 are poor, and about 2/3 are good. And study after study has shown the same thing. And this is not to do with their training. It's not to do with their qualifications. It's not to do with their age. I could give you a whole lecture about this. It deeply fascinates me. Encouragingly, in the MDMA phase 3, they took trauma-focused, they took therapists with experience in working with trauma, taught them quite briefly about how to use MDMA, and they rapidly got up to speed, producing excellent outcomes. Little caution around therapists coming in too hard with their therapy expertise when clients are in full psychedelic experience. The psychedelic experience itself tends to be the main teacher. It's helping them integrate afterwards and helping them to prepare beforehand that we probably have our main role. And trained in how to include psychedelic therapy. This is the MAPS package of training. I'll give you the links to that. So this gives you the links to how to get here. You can download their treatment manual for free. Ben Sesser is planning to run 7 to 10 day generic therapist training by the end of this year in Bristol. That's how you get in touch with him. And there are multiple options around the world, actually. And that's Ben. You can read it when you go back on the slides. Personal experience. This is a very interesting research paper looking at its value. How do you get it? Well, psychedelic truffles are legal in the Netherlands. This gives you some links. This is our network. We had 5 retreats set up before COVID hit. They're postponed, but they will happen, I think. It's just a question of some delay. This is my own website. I took 8 psilocybin trips last year, largely to remind myself of the mountain range. And this describes and gives you a lot of practical information about it. So these are some of the suggested ingredients. This is our Psychedelic Health Professionals Network website. If you go into it, you'll find all these slides, for example, downloadable. This is the web address. You can get the slides, tons of information, free quarterly newsletter, and an annual membership gets you access to an orientation integration group, a regularly updating WhatsApp research group, and the experience retreats. So I hope you've enjoyed that. It was a little rapid, but you can go digging back into the slides. So thank you very much indeed.
Thank you. Thank you so much, James. And I know it was a vast task that I had given you in terms of condensing the world of therapeutic psychedelic use into half an hour. And I think you did amazingly well. And there's so much more resources available there in your slides. Loads of really excellent papers to read, films to watch, lectures to watch. So I think that's I think you've done a really amazing job of just giving us that overview, giving us a real taste of it, and lots of resources to go and do further reading on. But we do have time for some questions. So please type your questions in. We've got plenty of time to get into some of the parts that James wasn't able to go into in detail, if any of them you find interesting. So I have one question in so far, or maybe a comment. There's maybe more comment. This is from Indu, and she says, I was at a virtual meditation retreat yesterday, a first for me. Some of the experienced attendees talked about experiences similar to the aftermath of taking LSD. I have no personal experience. I am totally intrigued. Okay, so James, do you have any comments on that about the similarity between meditation and psychedelic experiences?
I think it's deeply intriguing. I've been meditating regularly for 50 years, and that was triggered by my experiences taking LSD as a student. So my own background is I was reading philosophy, and back in the late 60s, and I took a series of LSD trips and changed to reading medicine and took up meditation, which I've been practicing for 50 years now. And I think that there are hugely intriguing overlaps. John Hopkins has done a very interesting study. I don't know how long I've got. I could talk for ages about this, where they introduced people to meditation and other spiritual practices, and then gave them psilocybin or placebo, and then continued with the meditation practices, and then looked at what happened at follow-up. And it was absolutely fascinating. They had high dose meditation practice and low dose or medium dose, and high dose psilocybin or placebo dose psilocybin. And they looked at well-being. They looked at a whole variety of well-being and altruistic outcomes. And it was very clear that the psilocybin just vastly put a kind of rocket boost on the meditation practice. There's another study where they took experienced meditators in a meditation retreat and gave them psilocybin or placebo. And again, both in terms of brain imaging and in follow-up terms with their meditation, there were just very encouraging outcomes. Our PHP network actually had a meditation and psilocybin retreat scheduled for this autumn, but it may be delayed, unfortunately.
Yes, and those retreats were to take place in Holland, where it is legal, isn't that right?
That's right. Yep, it is.
Yeah.
Fascinating.
Yeah. Okay, so thanks for that, James. It's really fascinating, the link there between, or the similarities between psychedelics and meditation. And I see there was lots of resources on the slides with some further information on that as well. I have a question from Julie. Hiya, Julie. So Julie is wondering if James can comment on the use of psychedelics in substance use and replacing one addiction with another. Is this an issue, and how is it managed?
I would kind of challenge you to get addicted to classic psychedelics. It's kind of never been reported, not in the classical kind of addiction terms. So classic psychedelics like psilocybin genuinely are not addictive. When you look at things like ketamine, then yes, you have potential problems. And MDMA, somewhere intermediate, I think. But for the classic psychedelics, it really isn't a problem. Not least because if you keep taking them, you deactivate your 5-HTP2AR receptor, and I mean it just becomes desensitized. So, but these experiences are not they're not fun. I mean, somebody said, what did they say? God is not nice. God is no uncle. God is an earthquake. And I would say the same for psilocybin. It's not, if you take psilocybin thinking this is just going to be, high dose, this is going to be a load of fun, you're going to get dumped on your backside fairly quickly. I took my first psilocybin high dose, first psychedelic trip for about 50 years last spring. And I've meditated for 50 years with my legs crossed. Since last year, I've meditated kneeling. The reason is for humility. It's not, it's something to be taken with deep respect, I think.
And James, could you comment a little, just on that point, could you comment a little bit about what the sort of setting, what that psychedelic experience in the therapeutic setting is actually like? Because I know for a lot of us working in the field of drug and alcohol, whenever we think of psychedelics, well, whenever I do, it's this sort of young people, they're taking a lot of magic mushrooms, they're ended up getting into difficulties, they're really doing it in quite a reckless way. And maybe sometimes that's what comes to mind whenever we think of using psychedelics. But I'm aware that in the therapeutic setting, it's very different than that. So maybe you could just talk about that a little bit.
So I would say that the vast majority of all the psychedelic research studies that you'll see will have used almost certainly a very similar kind of approach, where the client, the patient, is seen typically by a pair of therapists. We can discuss maybe how essential that is, but typically by a pair of therapists who will get to know them and help them to orientate, typically over about 3 sessions. And then they will sit with the client over 6 to 8 hours of the psychedelic experience. This is whether it's with psilocybin or MDMA. The client typically will wear headphones and an eye mask and spend most of the time lying down, going inwards, listening to a playlist that basically tries to helps you to go in. And what happens is the psychedelic kind of dissolves so many barriers that things like memory processes and connection to emotion and at higher doses, even one's own ego processes kind of become liquid. And so you're looking at the possibility of something reforming in a dramatically different way. You're looking at the possibility of insights that, repressed material, quite possibly, that one just hasn't had access to. And the trip sitters or the guides, or what are we going to call them, sit with you over that time period. And then as you come back, typically Ben Sesser in Bristol talks about getting the patients to stay overnight in the clinic, and then going in the next morning, the 2 therapists, and that integration session the next morning, an hour and a half with them, often being the most important one. But typically you then meet them again a couple more times, and then give them another similar experience, and again meet with them 3 times, and then possibly a third. So you're looking at maybe, 10, maybe a dozen typical standard psychotherapy sessions, preparing and integrating, and then these 2 or 3 hugely powerful day-long journeys would be a typical kind of pattern.
Yeah, thank you, James. So it's really about creating a really safe sort of therapeutic relationship and a really safe environment. It's this thing about the set and the setting, isn't it? That those things have to be really safe and really held, and to allow the healing work to really take place.
I mean, if you've done your preparatory stuff, so the person isn't taking, an inappropriate medication, and you've selected out, people who are more risk, the main risk in the session itself is extreme anxiety. In general, you don't have much risk in the session, other than terror, I would say. And that doesn't have to be the case. I mean, if you help somebody prepare and so on, that's, it's unlikely that you're going to hit these kinds of, but if somebody is just, doesn't really know what they're doing, takes some kind of, poor mix in some kind of environment where they don't have much support, they may have a wonderful experience, but they may not. I mean, I started this stuff as a student, then I had a long gap of several decades, but as a student, yes, I was reckless because we didn't know better. Now I would use it very, very differently. Yeah.
Okay, thanks, James. A few more questions here. This one is from Derek. Hiya, Derek. Derek's works in the Simon Community Low Threshold Services, and he's asking, do SNRI meds impact on treatment like SSRI meds do?
Yeah, I would be very dubious. I would definitely not have somebody on SNRIs with a psychedelic trip. And there is some work actually on duloxetine showing that it tends to block MDMA effects. So, you may move into, with the SSRIs and the SNRIs and classic psychedelics, I would like to see more research. The data is interesting and intriguing, but at the moment, the standard procedure would be withdrawal from the medication before you take the trip, which needs some management sometimes.
Okay, thanks for that, James. Let's see. I'm just looking now. Mark has sent me a question privately here. Given the tension that often exists between the medical and psychological model, where does treatment sit?
Yeah,
that's a can of worms.
I think it's at least two things. One is I think it's a deeply intriguing scientific question, actually, and I think there's not only a tension between a medical and biological and a psychological model. There's a tension between a psychological model and a transpersonal model as well, actually. So the best predictor of good outcome in general is the scores on the mystical experience questionnaire, which lots of people working psychologically are rather uncomfortable with. So fascinating, yes.
Great. Okay, so I have another question about James has sent me this privately, asking what is the recommended prescribed amount of ketamine to use in a session? Now, I know you mightn't be as up to speed with that kind of information.
So I'm not particularly up to speed with the ketamine literature. What I am up to speed with would be that there's huge variation, actually. Not only variation in dose, but also variation in means of kind of how one accesses it, from kind of intravenous to lozenges and everything in between, with I think the only way that it's kind of on license would be for depression intranasally, actually. I think the intravenous is off license, so very widely used. So huge variation. Those early slides I gave you will give you much more detail of that.
Great, thank you. Thanks for that, James. Let's see now, there's another comment about the meditation. This is Maggie Lavery, and she has said, hi Maggie, wherever you are, or your video's off.
It's not done.
Oh, I hear you, Maggie, hiya. Meditation is an altered state of consciousness. Is it possible that it's quicker to take a substance rather than have time in the busy world to alter it through making time? I meditate often and wonder how you find moving to the knees. So a couple of things there. Is it a replacement? Can psychedelics replace meditation?
No, I mean, at the moment, the data on microdosing is extremely unclear. And so if you're not looking at microdosing, you're not looking at taking psychedelics on any kind of daily basis. And so I would say a psychedelic, would be more like a meditation retreat, if you like. Whereas, I mean, what interests me very much indeed, and I think the research literature is still absolutely out on this, is how do you help people who have what potentially is a life-changing experience integrate that? And some years ago, 10 years ago or so, I nearly died on a mountain, and I was hauled off with a helicopter. And I was very aware that that could dramatically change how much I appreciated being alive for the rest of my days, or within a few months I could forget it and it would have made no difference. And it's the same is true, I think, for pretty much all huge experiences. And high-dose psychedelic trips are huge experiences that people can integrate them and move forward with them, often using, for example, forms of meditation. Or they may just go, that was far out, wasn't it? That thing I did 3 years ago, I've kind of forgotten it.
Yeah. So James, that's a really important point, I guess, that it's about what you do with it. It's not the psychedelic therapy itself. It's not just about that experience. It's really, I mean, it can bring about some dramatic changes, but it can often be, you know, what you do with that and how you integrate what you've learned into your life. So it's not just as easy as taking something and it fixes you. It doesn't work like that. It's kind of a different model, isn't it?
Yes. I mean, I know Ben Sessa, using MDMA for alcohol in Bristol, was saying, you know, in some ways, I mean, what it is an extraordinary enhancer of the psychological intervention, is what he's said. I think that's partly true, but I certainly think, you know, my experiences last year taking psilocybin in the Netherlands, I said, and it's true, were the most profound spiritual experiences of my life. I didn't say they were the most important, because I don't think I know whether they're important or not for several more years, and that depends on what I do with them. So I think it's the same with other profound life experiences, like my experience with the mountain and the helicopter. You know, what do you do with it? How do you do that? You know, and that's part of, I think, you know, one of the things the PHP network does is they run a monthly online integration group looking at exactly this. You know, how do we carry this forward? How does somebody take an experience and use it almost like, I don't know, kind of fertilizer for really healthy change?
Great. Thanks, James. And we're very happy that you made it off that mountain and you're here with us. Okay. Ernest Purvis is asking, how are policymakers and the pharmaceutical corporate lobby responding to the research and development in these therapies?
The policymakers, I'm sure it's very mixed. It was interesting that the Johns Hopkins people in the States went along having got these really extraordinary results with people facing end-of-life severe anxiety and distress. And they were giving them psilocybin and producing these really helpful kind of changes. And they went along to get more research permission from the policy, from the kind of people who are looking at the legality in the States, the big organizational group. And then, to their amazement, it was the organization that said, have you considered using this with treatment-resistant depression? Because that would be really useful for us, you know, as a society. So it was actually introduced to the researchers from the kind of, you know, federal organization, that maybe they should look at this much bigger area. So I'm sure it's very mixed. With the drug companies, I would have thought they're a bit anxious about it, you know. Instead of having my SSRI that I'm going to be giving all these people every day for the next 20 years, somebody's saying, why don't you take 3 psilocybin doses and, you know, along with the psychotherapy? I mean, I don't think it's going to be as straightforward as that, but it is a very different model. And I think drug makers are probably a bit anxious about it. what I think that, what some of them are doing, which I have mixed feelings about, is either funding research and looking at how they can produce profit out of that. So Compass Pathways, who are doing the biggest treatment-resistant depression study, are a commercially funded organization. And this it's great that the research is being done, but, where's it going to, if you see what I mean? And similarly, there's something called MindMed, which is just come in and it's a company looking for profit, and they're looking at a lot of the LSD work. So I think it's it's something to keep a real eye on, whether it's somewhat hijacked by the profit motive or held back by politicians going, if I'm going to get voted in, I need to be tough on drugs, kind of thing. So I think it's tricky, but I think there's a real change.
Mm. And another question just related to that, James. Ed Seipler, who's our DAC chair in the Southeastern area, he's just asking there, has our demonization of drugs impacted on the future use of psychedelics therapeutically?
I think it's already had a vast impact on psychedelics. Vast. All of this stuff was brewing nicely in the early 70s. It was already being used for people who were suffering horribly with depression and trauma and addiction. And then they went and basically wiped out the evolving research for 30 years. And the amount of suffering that's been caused by that, I think, is horrible. So I think that I think there's a change. I think people are more open to trying to find out actually what the facts are. But I think David Knapp would say it's one of the the worst examples of scientific kind of disruption in the medical field that we've had. It's shocking, actually, how the politicians were able to come in and just do that.
Mm.
But it's changing.
And there still is stigma and a lot of, I guess, negative beliefs held around psychedelics from those days. So I guess it's about, it seems that the researchers are sort of treading quite carefully and trying to move forward in a very responsible kind of manner, and to try and change the face of how people perceive psychedelics, maybe.
I mean, I'm fairly hard-nosed as far as evidence is concerned, and I just think it's I think we need to follow the data. Let's see what works. It's looking good.
Okay, thanks, James. I think it's just one final question here. DMT. So I know that with young people, DMT is trending, or it's popular. It's growing in popularity, and YouTube actually is full of videos of young people, or not even young people smoking DMT and recounting their experiences. But Pauline O'Reilly here is asking. She has young people telling her they have experienced DMT as a cracking sensation in their brain, like an awakening. And do you have, what are your thoughts on that?
I suppose kind of three thoughts. So DMT is kind of, I would identify as the major active psychedelic in ayahuasca, and so I would say that the set and the setting are hugely important in that kind of situation. So how is it being taken, with what kind of attitude, what's going on, if you like. So I think there's something about set and setting. I think there's something intriguing about the possibility of some 5-MeO DMT or whatever it is, producing a very powerful psychedelic experience across a very shortened time frame. So, if somebody went out into something quite extraordinary and was back within an hour, would that make the experience less potentially therapeutic? Or would it actually be a wonderful way of making it more accessible? So I think there's some intriguing questions around that. Yes, so those would be my main feelings about it.
Yeah. Okay, thank you. And I've just overlooked one there. Julianne was asking if you could tell us more about the study with the rat you were chatting about just before we broke off.
Okay, the reason I got intrigued by this study was actually more something I didn't mention. So what they did, I think I can certainly send you the links to the study, it's not a problem. But what they did was they took rats who were kind of depressed, i.e. when confronted with a forced swim test, they tended to give up quickly. And they gave them LSD, but they didn't get the dosing right, or ketamine, or psilocybin. And what they showed was the psilocybin produced considerably more persisting effects than the ketamine. But then there was this intriguing thing that half the rats with the psilocybin were given a learning experience where they were put into an open-armed maze where they could, while they were still in the neuroplastic state of the couple of weeks after the psilocybin, actually have an experience of facing anxiety and exploring in a way they wouldn't have done before. Or they were given the psilocybin without that opportunity to learn new behaviors. And then they looked at follow-up, and the rats who'd had the psilocybin and the opportunity to act differently did better than the rats who'd been given the psilocybin, but without the post-trip learning experience, which is fascinating around integration and all kinds of interesting ideas. So it was a very interesting study in lots of ways.
Okay. Thank you very much for that, James. And I could talk to you all day, James, about all of this. It's absolutely fascinating. But I think we've answered all the questions that people have posed, which is great. And I think you'll have your details around there about how people can maybe get in touch with you if they have any further questions, and all that information will go out on the slides as well. Excuse me. So thank you, James, thank you so much, James, for that. Absolutely fascinating, and lots of people saying thank you and really enjoyed your presentation. So thank you.